My name is Kirk Geyer, and I'm the General Manager of Biomedica Diagnostics. On behalf of the Biomedica team, it's my pleasure to welcome you to our series of scientific discussions with key opinion leaders in the field of thrombosis and hemostasis. I hope that you will find these topics both informative and stimulating. At the end of each video, you will find an email address where you may send us your comments and opinions. We would also appreciate your suggestions for future topics that may interest you. Now, on behalf of Biomedica, please enjoy.
Hello and welcome to Coag Conversations, an educational series sponsored by Biomedica Diagnostics of Windsor, Nova Scotia, Canada. Our topic for this three-part series is alternate warfarin monitoring when the prothrombin time is unreliable. We will focus on anticoagulation management in antiphospholipid syndrome. I'm George Fritzma, faculty for the University of Alabama at Birmingham School of Medicine, Division of Laboratory Medicine, and proprietor of the Fritzma Factor, your interactive hemostasis resource. We welcome Nicole Zantek, MD, PhD, professor, Department of Laboratory Medicine and Pathology, University of Minnesota Medical School. Dr. Zantek is a pathologist with expertise in transfusion medicine and blood banking. She is the medical director of the Special Coagulation Laboratory and conducts research in the areas of hemostasis, transfusion medicine, and blood utilization. She is interested in general issues surrounding hemostasis test performance, utilization, and interpretation. In particular, she is exploring how medical circuits such as ventricular assist devices and apheresis cell separators influence hemostasis in adult and pediatric patients. Dr. Zantek is also interested in advancing transfusion medicine and blood utilization practices. We begin this third conversation with a discussion entitled Alternative Means for Monitoring DOACs and Warfarin. And we'll turn this over to our speaker, Dr. Nicole Zantek. And let's start with talking a little bit about the DOACs. We covered this somewhat in conversation number 2, but if you don't mind, we'll start again. Is there a need to ever monitor the plasma level of the DOACs? And then is it important to monitor the plasma level of warfarin?
Well, certainly DOACs, as I mentioned before, have times when they're worthwhile to check. And even though we don't have good therapeutic ranges established like we have for warfarin, we can sort of judge against what have been reported as on therapy ranges. And so in patients with antiphospholipid syndrome, the indications for that kind of testing is similar. So, are they on a medication that interferes? Are they at extremes of weight? Have they had a thrombotic event while on it? And do you want to check to make sure that they were at a therapeutic level? And then like before they go into an invasive procedure to see if there's still drug on board or if there's, bleeding more or bleeding, then someone may want to check that. So, but routinely we don't monitor DOACs. Warfarin, on the other hand, and other vitamin K antagonists, we typically do need to monitor because there's a fair bit of variation in response to drug, and also over time, people's response can vary due to things like dietary, vitamin K intake, medications, and other things that affect the levels. So it is routine to monitor vitamin K antagonists, and it's would be no different in a patient with antiphospholipid syndrome.
How do, when you're monitoring warfarin, can you use the PT-INR? I know we talked about this a little bit in conversation number 2. How effective is the PT-INR? And then let's look at some alternatives as well.
in some patients, the PTINR may be okay, and it's the prothrombin time is contains phospholipids, so it can be affected by antiphospholipid antibodies. So it's important to get a baseline. If the baseline is elevated, then probably, up front that you can't do that because it's already up, so you're going to potentially underestimate the dosing that you'll need to actually be in a therapeutic zone. But it can be used at times in some patients. If it's unreliable, like it is elevated, then you consider using alternative methods. So probably the more common of the alternative methods is a chromogenic factor 10 assay. And this is an assay that's done by diluting the patient's sample. So it's a single dilution, and then you add another snake venom, as snakes are key to understanding Coag, Russell viper venom, and that activates factor 10. And so then the factor 10 is activated in the patient sample, and then you add a chromogenic substrate, so something for that factor 10 to cleave. And then it releases a colored compound when it's cleaved. And then you measure the generation of that colored compound. So the more that's released, the more active the factor 10 was. And so that test is relatively phospholipid independent, so antiphospholipid antibodies don't typically interfere in it. And so it can be something that's used. There is, though, unlike the standard INR of therapeutic range of like 2 to 3, there isn't a universally accepted therapeutic range for chromogenic factor 10, in that they've kind of varied somewhere in the range of 20, 25 to 40, 45 is sort of what has been reported. And so it can be used in place of warfarin monitoring. There aren't the same warfarin dosing protocols aren't as widely established using chromogenic factor 10 as they are for adjusting based on the PTINR, but sites adapt protocols to kind of match so that an INR of 2 to 3, if, for example, they would set it matches maybe approximately 20 to 40, where the INR of 2 equals the 40, the INR of 3 equals the 20, and you make adjustments sort of based on that sort of an algorithm.
Is that the chromogenic factor 10? It's interesting. I know that was developed and reported on back around 2008, 2009, and actually was being used in your facility. Is that a lab developed test, or is it available commercially? And how often are you using that?
So it is commercially available. So and I would say we run several we have several patients throughout our system that are being followed by chromogenic 10. Many of them have antiphospholipid syndrome. Sometimes patients otherwise have reasons that the INR is thought to be unreliable. A common scenario being that we see from inpatient in the hospital are patients on direct thrombin inhibitors that are transitioning to a vitamin K antagonist. So we'll see testing in that scenario as well. So it's not all patients with antiphospholipid syndrome. Some of the patients are being followed that way.
Is the chromogenic 10, I know that the studies I've seen, they do have correlations like you've described that compare it to the INR. How is it at detecting an overdose of warfarin? In other words, what does it have a good lower limit of detection?
I think think of sort of like thresholds. So to know if someone's like in a therapeutic range, it's pretty good. So like if you use that 45%,
Yeah.
saying if you're below than 45, you're probably in a therapeutic range. It has, pretty good to say that your INR is probably above 2. Um, in the same patient that you're using it for, because it's unreliable, they're more likely to have an INR that's even higher. So in patients, if you are at an INR or a chromogenic 10 of 20%, for example, you'll see patients with antiphospholipid syndrome, more of them will have super therapeutic INRs than patients that are being used for a different reason. If you just were using it, correlating testing, like for a study, more of them will be in the 2 to 3 zone than out of the 2 to 3 zone. But as you get lower and lower in factor 10 level, then it gets to be less and less reliable, just like INRs. The higher and higher you go, the difference between an 8 and a 10 is small differences in factor levels. So it gets to be issues there. And there's some, the various forms of factor 10 start to play a little bit more when you're down at the really low levels in terms of determining it. But the closer you are to that 2 to 3, but it's not perfect. And from our own data, you take a whole bunch of samples and you run them both, it's not a perfect correlation. It's a little bit of scatter. And that's been seen on all the studies that I've seen, there's a bit of scatter in there.
Usually, chromogenic testing in general has better precision than clot-based testing, and it's a question as to the correlation and how sensitive and specific it is. Are you seeing pretty good precision if you're running repeat assays of chromogenic 10?
I think if you just like put it on an analyzer and do intra-run and inter-run, it's pretty good. And
Yeah.
individual patients still have some fluctuations, between, like, we get a sample now and they come back in 3 weeks, we get our sample, we'll see some variation just because of the variation. It's not, there are things that will affect that has pretty good reproducibility. I mean, on the same sample, running it over and over again, you'll see that as well with the PTINR. But it's sort of like, what's going to make this test be less accurate than the INR? Sometimes it's other things. So interference from specimen color issues affect the reliability of this test. So is
Yeah.
there hemolysis? Is there icterus? Is there lipemia? Because it's a chromogenic test, so they'll start throwing off the results. So those are scenarios where, we get a specimen, then that's not a comfortable result. Those will, if they have a lot of hemolysis, for example, we'll cancel it because it's going to affect this measurement. Also, in patients where it's not like antiphospholipid syndrome, where we're trying to just get around that antiphospholipid antibody, patients with liver disease sometimes have unreliable INR. Here, it's also a little bit tricky to figure out where's the right spot to be, because they have a bigger picture that's involving, the coagulation factors and the INR and how they correlate. And then if you're trying to transition somehow to a direct oral anticoagulant to and from warfarin, this test will be interfered with that. So we've seen interference with that when they've gotten testing. But on the upside, it's not interfered with direct thrombin inhibitors. It gives us
All
an
right.
opportunity to separate those out.
That's interesting. So would you say that we could replace the PTINR with the chromogenic 10 altogether?
No, I don't think we could. I mean, I don't think there's enough known to make it the widespread. I think for example, we don't have a therapeutic range that's clearly well uniformly accepted and established. And I think there's patients, hemolysis, icterus, lipemia, that kind of stuff. The other reason is that it's more inconvenient. If you're just can be routinely followed by INR, a lot of times you can do, patient self-testing with a home monitor, or you can go in to a clinic and just have a finger stick and do it on a point of care device. where this is a venous draw, and only some labs in an area will run it. So many times it has to get sent in. So then it got all that extra step and a delay between the testing and the response and management of the patient's warfarin. So I don't know that it would replace it. I think even though it's more precise, it has its own issues. One of the scenarios too where we see issues correlating with INR is when someone starts and stops. So when you first start on warfarin, the INR is really driven by factor 7 and that its half-life. And factor 10 takes a little bit to catch up because it has a longer half-life. But when you're kind of stable, then it kind of works well. They're matched better. But the same if you stop warfarin, the factor 7 will, has a shorter half-life, so it'll correct. So the INR will correct, but the factor 10 will kind of lag behind. So we see some issues with how things look kind of when you're moving, I would say, on warfarin anticoagulation. And that can be a tricky time to use the test sometimes.
That was sort of a loaded question, of course, I just want to challenge you with that, but it does seem as though the chromogenic 10 has a lot going for it, but I do understand that all of the chromogenics do have the problem that if it's a highly colored specimen, that can affect the results. Is there any other assay that you've considered than the PT-INR in following warfarin therapy? For example, I know thrombin times have been modified to follow the vitamin K antagonists. You mentioned factor 7 levels. Would factor 7 assay be more sensitive to the changes since factor 7 is a low concentration factor? Have you tried anything like that, thrombin time or factor 7?
I wouldn't, it must be a modification because generally the thrombin time itself is normal in an individual on therapeutic warfarin.
Right.
So it might be a modification that I'm not sure of that one. Just like factor 10, chromogenic 10, you could measure other factors.
Mhm.
So, the other vitamin K, 2, 7, 9, 10. So 10 is used part because there's a nice chromogenic acid. But also 2 and 10 are the key sort of to really control thrombin generation. So
Yeah.
there's been some data that suggests that 7 and 9, I mean, they're important, obviously, but they're not as vital to really getting thrombin generation under control, which is what you need to prevent the thrombus. So the other assay that some labs have used has been factor 2 testing then to test for that other major component.
Yeah.
So the factor 2 testing is often still done with the classic one-stage method.
Hmm.
You dilute the patient sample and you mix it with factor 2 deficient plasma. Um, that assay, again, doesn't have a standardized therapeutic range.
Right. Yeah.
But hopefully the dilution helps you get around some of the effects of the antiphospholipid antibodies, but it's problematic if the patient actually had the type of lupus anticoagulant, so the hypoprothrombemia. So they get that they get associated with low factor 2, then that assay doesn't work. So I think that assay, the using a factor 2 is just it's still possible, but I think labs have moved away from it because it has more potentials for interference.
Hmm.
Um, and I just think the targeted range has even been less well established. So I think it's a little, there's less guidance on how to use it. Um, but it's certainly, something. And then there are other, modifications of the prothrombin time, and I haven't seen any of these used in the US, but like where the fixed PT where they make it more focused on the factor 2 and 10 activity by absorbing plasma and then adding it to your sample. But there are other strategies being looked at, and I certainly think we can improve upon just your big old generic PTINR to sort of narrow it in to targeting the real effects of the vitamin K antagonists and getting away from things that interfere it. So I think there's still opportunity to make new tests and to improve upon the tests we have.
Well, this has been really interesting. I was really surprised to learn that there are several facilities that do use the chromogenic factor 10 successfully, just in the conditions that you've described. And I've also, there was a time, probably around 2014 or 2015, when I thought, and maybe everybody thought, well, warfarin has seen its last days. We aren't going to have to bother monitoring warfarin anymore, so why bother with the PTINR or the chromogenic factor 10? Truth is, I believe we've got almost as much warfarin therapy going on now as we did even before the DOACs came along, or at least there's still quite a bit. Is that what you're seeing also?
I think definitely we're seeing new people, general indication used for anticoagulation, that many of those new starting anticoagulation are being put on the direct oral anticoagulants. And then the antiphospholipid group, you have that, are they triple positive and things like that to make that some decision. I think if you're stable on vitamin K antagonists, it's a relatively cheap drug, and there's so much history with it, and we have readily available reversal agents, and people know how to use it and respond to it. I think, at least I don't see it disappearing. It's gonna persistently have a role in that anticoagulation realm. We'll fine tune it. This patient might be better to this one or that one, but I think it's not going away.
Very good. Well, this has certainly been a good series and a great opportunity to look at not only lupus anticoagulant and antiphospholipid antibody testing, but also to look at some of the pitfalls and some of the challenges in managing that testing and in managing the therapy as well. So thank you so much, Dr. Zantek, for sharing your expertise with us, and thanks to everybody for listening to Conversations 1, 2, and 3 on this subject. And watch here for more conversations in the future. Thank you and goodbye.